I'm so excited to finally meet you, if not in person. This is as good as it gets, I have to tell you. I'm joined tonight for those of you who have joined us, and I'm seeing a lot of people coming on here. This is Dr. Joe Dusseldorf. He's from Sydney, Australia. Can I take you on a little walk down memory lane here for a minute?
Yeah.
So I went back and looked at my IG account, and when the pandemic started, Dr. Dusseldorf, I did a few IG lives. And so I think you saw one of them and you reached out to me. And it was April 30th of this year.
All right.
I went back and looked, and you said, I'm trying to bring awareness to those that don't have the information about breast reconstruction in Australia because you feel like there's information lacking. Well, that's why I started the foundation. It's really, we have some of that same issue over here in the US. So we've been communicating ever since. And what I'm really excited about is that we got you on the closed Facebook group. And now you've got folks in Australia that are talking to you there. In fact, we have one gal who asked a question for our interview tonight. So let's just get started and tell me
Yeah.
what you're doing over there with breast reconstruction. Because it's got to be different. The process has to be a little different. The intake, I guess. Maybe not the mechanics of the surgery, but the intake. So tell us about that.
Yeah. Well, I mean, what's fascinating to me is, as you say, the technical factors of the surgery. Like I've listened to a lot of the talks by Minas and a lot of your other journey surgeons, and I agree completely with what their approach is. I think they're obviously doing really high volumes of DEPs, and they've got really nice systematic way of doing things. And I agree with a lot of the stuff that's the comments there. So that's reassuring to know that we're on the same page as where the current thinking around breast reconstruction. But there are some differences in Australia with our health system that make it in some respects a little bit harder for people to access care. And I think we still have gatekeepers that really, in a lot of cases, dictate the avenues patients take. And those gatekeepers are usually the breast surgeon or the cancer surgeon, and probably also the treating oncologist and radiation therapists and things. Those are the ones that kind of meet. Everyone meets first. Obviously, when you get a breast cancer diagnosis, most people's head doesn't go to reconstruction. It's a natural thing to want to treat the cancer first, and I think that's totally understandable and normal. But what I would advocate is a sooner conversation about reconstruction. That doesn't have to be in the same breath as the cancer treatment, but it can be shortly thereafter. Because and I also think it should also inform the cancer treatment. I think that there's a chance for us to think about the whole person, not just about a tumor or about a bunch of cells that have gone rogue. It's also about that person and how they feel about their body, as a whole. And that's something which I would love to be involved more at the early stages with people, and just kind of also giving them that reassurance that we'll be able to look after this, that it's not, that people, I think, go into a state of mourning. They mourn that they're going to have to lose one or both breasts. But if you can immediately sort of follow that up with, but this we can make it, pretty close to what you had before, maybe even a couple of improvements, slight improvements. That's not the worst thing in the world. And as well as that, there is this really nice side effect, of the DEP flap, which is a flatter tummy. And I know a lot of women kind of have no idea that that's even on the table when they find out about breast reconstruction. In Australia, that could be 5 years after their cancer treatment. And I think that's 5 lost years in many settings where people who if they've been informed differently, they might not have chosen that path.
Yeah, what you're talking about really hits home for me. I think what you're speaking of is the coordinated care effort, and
Yeah.
it involves the breast surgeon, the oncologist, sometimes the radiation oncologist, and the plastic surgeon. And like you said, it is a step-by-step process. We always have to treat the cancer first, but there's no reason why this can't be brought into the conversation. Because I know the day that I went into my breast surgeon, I was just cloaked in anger and frustration. But I have to tell you, and for the viewers out there watching, because she was the first one who gave me all my options, I left her office today or that day with a sense of hope. And so I think that's what we can give to patients, and they can start thinking, you know, after the treatment, after the breast cancer is treated, what can they do for form and function to restore their body again? So that's a really good point.
And I think that's extremely powerful. Just that little taste of hope, is something that people can cling on to, and that's something which, in Australia, there's been a sense of you have to earn a reconstruction. I think that's something which I've heard from some of the older surgeons that have this mindset that a reconstruction was really only once even earned a remission, even 5 years down the line after the cancer had fully gone away, then you could consider a reconstruction. And I think that mindset has really shifted, and that we are advocating immediate reconstruction. And we talk about that at a higher level, through our breast societies and things. And there's some standard care treatment guidelines and things. And that it's written that if a woman's considering mastectomy, we should be offering reconstruction immediately. But it doesn't necessarily always translate to clinical practice. And so that's, I think, where I'm trying to use my own voice to talk to people directly, and people who maybe haven't started or just at the start of their cancer treatment, but also for women who have undergone a delayed approach, understanding what the treatment options are.
Yeah, absolutely. Because even in a delayed setting, you know, reconstructive results can be amazing. They were for me. I
Yeah,
say that.
that's exactly right. I think it's been a tried and tested approach. But the question mark I have over it is at what cost? There's a few of those, and if you can avoid any suffering in someone, why not? Like, I think that's, to me, if there is a good reason for not doing a reconstruction at the start, say they need a specific amount of radiation, or there's something about that the nipple has to be sacrificed for cancer reasons, or we'll talk a little bit about nipples, I think, later. But there's then that's fine. But I think that's all part of that personalized approach to the comprehensive care that you talked about, the continuum of care. And that's why I like to be in the conversation early on and actually be involved with those decisions.
Yeah.
And to me, the key is to personalize the decision making, and that's something which every woman is different, every person is different, and the way they feel about different parts of their body is going to be entirely different. It depends where they're at with their life, their children, their partner. There's so many different factors, not just how they feel about themselves. So all of those factors, I think, are important to understand before kind of making any recommendations.
Well, and I mean I think that is a challenge both for the patient but also for the surgeon, because not only do you have different body habitus to work with, but you have different lifestyles, different values from each patient. And so when each one enters the room, that whole shared decision-making process becomes very unique to that patient. And so, yeah.
Yeah, no, I totally agree with that. But that's also the kind of the joy of being a doctor, I think, is getting to know people. And like, I think that's it's a skill that takes time to build up. But once you kind of have that ability, and I like to think I've got at least a touch of that. You have to be a little bit empathetic to see, what people are saying to you, and reading between the lines as to what might hopefully suit them and make them more, live a happier life. So that's ultimately, I think, the driving force for me.
Yeah, well, it shows in your passion for your work, Dr. Dusseldorp.
Thank you.
And I think that, I just heard from a patient today that I talked to, and I mean, she hasn't even had her reconstruction yet, but she had her consult. She's got her date set, and she already feels good about her surgeon. And it's because they had that shared decision-making conversation. And I said, doesn't it feel good to start to feel like you're almost a family member? And you must feel that from your patients. You must feel that connection.
Yeah, I think particularly with breast reconstruction, because it's a, it's a staged process, and I think that's something which, I always say straight up off the bat, is that this is generally not, sort of a one and done kind of procedure. It often requires stages that are of differing complexities, but opportunity to do refinements and touch ups and things. And so I think that I always say that you don't have to worry about ever offending me about, if you don't like an element of something. I'm always going to be the most critical person of my own results, and I'm always going to be able to see little things. So if anything pops up, I always tell my patients to tell me, because that, and I want them to have that freedom to say, actually, there's a little lump here or a divot here, or there's something not perfect, because ultimately that's, you want to have that trust that I'm going to be, willing to hear that stuff, because you can imagine other situations where people were too afraid to say that they weren't happy with something, or and that's not what you want. I think you want
Yeah.
that open dialogue.
Good on you for telling them that right up front. Tell me, that's awesome.